Our second speaker is Dr. Henrik Zetterberg, who's professor of neurochemistry at the University of Gothenburg and University College London. He's going to be presenting on a cerebrospinal spinal fluid biomarker for neurodegenerative diseases.
Thank you very much for having me. I'm really delighted to be in this session. It's such an exciting field, and I am specialized in neurochemistry, clinical neurochemistry, working with fluid-based biomarkers for neurodegenerative diseases. And here we have seen a lot of developments recently, which also involves actually recent FDA clearance of some of the assays to measure CSF biomarkers. So we could take the next slide, please. So this is a little bit of a busy slide, but it depicts a neuron in the brain, and the typical Alzheimer disease-related brain changes are amyloid plaques that you see in the lower right of this picture, and then also neurofibrillary tangles that you see to the left in the picture in the neuronal soma. And these two key pathologies are present in the brain when you get Alzheimer's disease, perhaps 15 to 20 years before onset of the dementia phase of the disease. Especially beta amyloid plaques are very early when it comes to the onset of accumulation of these plaques. It often starts in the hippocampi and entorhinal cortex, and then the disease spreads across the brain. And it's often regarded as when you enter the clinical phase of the disease, the brain is, you have a lot of amyloid pathology everywhere, but then you also have neurofibrillary tangles composed of an axonal protein called tau. And the distribution of these tangles correlates with what types of brain regions that are affected, and that also correlates, of course, with the symptoms. So we could take the next slide. Here I just wanted to tell you that this presentation will deal with biomarkers for amyloid plaques and for tau tangle pathology in the form of phosphorylated tau. Next slide, please. We could take next slide also. So if we look into the literature in regards to fluid biomarkers for amyloid pathology of Alzheimer's disease, we have known for many, many years that cerebrospinal fluid concentration of 42 amino acid long beta amyloid is decreased in Alzheimer's disease. And when we develop biomarkers, of course, it's important to know what the biomarker reflects. And we have known for a long time that the core of the amyloid plaques are rich in the 42 amino acid long form of beta amyloid. This is a form of amyloid that all of us make. It is hydrophobic and it can aggregate at high concentrations, and then it starts to form these types of plaques. And this is a templated misfolding reaction, not dissimilar to prion diseases like Creutzfeldt-Jakob disease. So in Alzheimer's disease, lumbar CSF low levels of this protein, this small protein, indicates that it is stuck in the brain. And young people all have high levels, meaning that they maintain a beta 42 in solution. This has been seen in many studies. This is an extraction of the ALZ biomarker database that is available through ALZ Forum, open access database on the performance of different biomarkers for Alzheimer's disease. Next slide, please. Here we see an old study and the correlation between the biomarker in the body fluid on the y-axis and post-mortem data on amyloid plaque counts. And you see this type of relatively strong correlation between high plaque counts and low CSF beta 42 concentrations. And in the validation phase, it has been important to replicate this, of course, and also to relate it to imaging evidence of amyloid pathology in the brain. Next slide, please. Let's see, there we go. Perfect. And now we have the possibility of measuring amyloid in the brain in living people by amyloid PET, which is also now an approved test for amyloid pathology. And if we click once more on this slide, then we see here the relationship between amyloid PET signal on the x-axis and cerebrospinal fluid A beta 42 concentration on the y-axis. And then you see this type of almost bimodal correlations. You have people who are concordantly normal for both biomarkers. They have high CSF beta 42 concentration and low amyloid PET signal for amyloid pathology in the brain. And then you have people who are in the lower right quadrant who are concordantly abnormal with high amyloid PET signal and low CSF beta 42 concentration. We could click once more and once more. In this study, we also made a replication here to set the cut point, and we see that this is a quite replicable finding. And this overall result has been replicated across many, many studies now from research groups all over the world. And there are actually almost, I think it's 60 or 70 studies that show this type of pattern. So we think now that we understand CSF beta 42 as a biomarker. Next slide, please. But there are problems still, because if we measure CSF beta 42 concentration in people who have neuroinflammation, then we learned in the C and D panels here that patients with active neuroinflammation in the form of multiple sclerosis, they have lower levels of CSF beta 42. But in the A and B panels in the upper part of the figure, you also can see that other A beta forms that are more water soluble, C-terminally truncated A beta 38 and 40 that are in solution and do not aggregate in the brain, they are also lower. And this is not the case in Alzheimer's disease with plaque pathology, because then you have a selective reduction in A beta 42 concentration and the other A beta forms stay normal. Next slide, please. This is the case in normal pressure hydrocephalus also. So if you click once more, you see here that A beta peptides and soluble APP, the mother protein of A beta, all are reduced in normal pressure hydrocephalus. So here, for many years, we had a misconception in the field that normal pressure hydrocephalus had a high prevalence of amyloid pathology, but we now know that this is due to general disturbance in the amyloid metabolism. Next slide, please. The solution to this problem is to make a ratio, CSF beta 42 to 40 ratio. And this is our plaque pathology marker that has now also been approved as an IVD diagnostics. Next slide, please. Here you see the data on what happens to the biomarker performance when you combine A beta 42 with a water-soluble shorter A beta form and make a ratio. So in the A panel, the red line indicates the AUC, the diagnostic performance, one could say, of A beta 42 alone, and you get an AUC of 0.9, which is a good biomarker. But if you combine it with A beta 40 and 38 in the ratio, you reach almost complete concordance with amyloid PET. I should say here that the reference standard here is amyloid PET positivity, amyloid PET to determine amyloid positivity. These are two different assays, and that has also been an important part of validating this biomarker. Different assays that use similar or the same or slightly different antibodies give the same result overall, and they correlate, and there is also now a reference material and a reference method available to standardize these assays. Next slide, please. The biomarker has, the ratio has a bimodal distribution, which is a fascinating feature of this biomarker. So you are either normal, and that means that you are not depositing, which is the green normally distributed population here, or you are abnormal and you deposit amyloid. And there is a very small gray zone, which is an unusual feature of this test as a clinical chemistry test. Next slide, please. Using the test, we can also follow people when they start to develop amyloid pathology. And this is a study we did together with the Madison researchers, Sterling Johnson and Toby Betthauser. They invited people who were adults but had one or two parents with sporadic Alzheimer's disease, and they gave CSF and underwent repeated amyloid PET imaging. These people are at increased genetic risk for Alzheimer's disease, but it's the sporadic form. And you see here that people, when they are 40 to 50 years of age, if you look at the x-axis, you see that all are normal in the ratio. But from 50 years of age, people start to die down in the ratio, and that means that they start to accumulate amyloid. And that is evident in the rightmost panel here, where you see the trajectories of the amyloid PET signal increase over time. So the fluid biomarker is almost like a qualitative marker of when onset of amyloid accumulation starts. And with amyloid PET, you can quantify the progression of the amyloid accumulation over the brain tissue. And then you also see this interesting feature of amyloid PET, that people have relatively parallel trajectories of the slope at which they accumulate amyloid. Not trajectories of the slope, but the slope is quite parallel, which means that when the amyloid cascade has taken off, It happens independently of how you live your life. And the best way of stopping an amyloid cascade is, of course, to remove the substrate of the aggregation process. And this is also obviously what we all hope that the anti-amyloid antibodies will do, and thereby slowing down the whole process. Next slide, please. One can line up people and define a time point 0 when they start to accumulate. And then you see that a few years later, a few years after people have become amyloid positive according to the CSF test, then they also become amyloid PET positive. Next slide, please. Plasma A-beta is a very hot topic. The blood test for Alzheimer's disease, it has been claimed if we could measure A-beta, but over many years, we have been able to measure plasma A-beta, but that we haven't had any concordant or interpretable results. So 1 in this graph indicates no change. And throughout the years, we have had studies publishing increased or decreased levels, and most published no change. Next slide, please. But now we have an amyloid test in blood, which was developed by Randy Bateman's team in St. Louis, and you will also see some other parallel developments, where in this test you use antibodies to extract all beta amyloid from the plasma sample. You then digest the amyloid and measure the beta 42/40 ratio by mass spectrometry, and then you see this type of reduction in the ratio. We see that we have a clear group level difference and an AUC which is quite high of this test. Next slide, please. We see also here, you can push once more or click once more. This is another type of assay from an Australian-Japanese collaboration, also mass spec based, where you pull out A-beta with antibodies. And then they actually here used an inverted ratio, which is the reason for why you see increased and not decreased levels of A-beta in amyloid positive people. Next slide, please. We could actually skip this slide and jump to, if we click once more, we can click once more. There we go. The mass spec based assays, they are difficult to run in a clinical laboratory setting on samples that come in ad hoc. So we have worked together with Roche to develop an immunoassay, and this is data from an assay we developed on the Cobas platform. And in the left part you see amyloid negative people, and in the right part amyloid positive people. And there you see you get by this clinical chemistry fully automated test is around 0.8 or 84 in this case. But you also see that individual patients end up in, it's very hard to tell if an individual patient is amyloid positive or negative. Next slide, please. And here you also see part of the problem. In the B panel, you see the fold change of the A-beta ratio in CSF with a 50% reduction and a small overlap of patients who are amyloid PET positive and negative. And then in the leftmost A panel, you see that the reduction in plasma is only 10–12% because it happens on top of peripherally produced amyloid. And this is really the challenge with this amyloid test. Next slide, please. We can jump on more. And this is another way of putting it. If you look at the rightmost part of this figure, you see CSF phospho-tau A-beta 42 ratios. And you see that PET negative people who don't have amyloid, they end up nicely in the lower right of this graph. And amyloid PET positive red circles, they are in the leftmost part. And there is a lot of wiggle room in the C panel where the assay could drift a little bit without causing too many people to be misclassified. But if you look at the plasma A-beta 42/40 ratio in the leftmost part of the panel, you see this group level difference, but you see that amyloid PET positive and negative people are very close. So if anything happens to this test in clinical laboratory practice, you will have a lot of people moving across the threshold. So this is a little bit of a scary assay to use in a clinical chemistry lab week by week, because it has, in clinical chemistry, we would call this test not robust enough, or sometimes people, clinical chemists also talk about the ruggedness of the test. Next slide, please. So if one would ask the question, can we diagnose amyloid pathology with a blood test? Are we there yet? For group level enrichment and screening, I would say yes, if you accept that individuals might be a little bit misclassified. For example, the as a pre-screen for entering a clinical trial where amyloid pathology will be confirmed by CSF or PET. For individual diagnostics, we are not there yet, but maybe one can at least say that we start to see some results that are starting to look really promising. Next slide, please. I will now end with tau pathology, and I will be quite brief here also. So next slide. Phospho-tau is increased in Alzheimer's disease. That is known for a long time, and that comes from neurons that are exposed to amyloid, and they phosphorylate and secrete tau, and the levels in the CSF get higher. Next slide. But in other tauopathies like frontotemporal dementia and PSP, the levels are low. So this is an Alzheimer's-specific test, and it reflects the amyloid, the disturbance in tau homeostasis in amyloid-exposed neurons. That has been shown by a lot of basic science research in iPS-derived neurons, animals, and also in patients where it has been possible to measure A beta production and clearance rate by a certain methodology called SILK. Next slide, please. We could click once more. There are different forms of tau that we can measure, different forms of phosphorylated tau, but they behave relatively similarly. Next slide, please. And we can now measure this in blood. And in the leftmost part, you see the change of phospho-tau levels to 31 in patients with super small amounts of amyloid in the brain, and then increasing amounts. And you see that already when patients get a little bit amyloid positive, the plasma biomarker detects that, and then it increases to threefold, even fourfold in blood. Next slide, please. It can be used in diagnostic algorithms to predict Alzheimer's disease dementia in people with subjective or mild cognitive impairment. And if one only does the plasma phospho-tau test, the AUC is 0.8 in this study. If you also include some brief cognitive tests, you reach 0.9. Next slide, please. You can also use different types of phospho-taus and reach the same conclusion of around 0.9 in AUC. Next slide, please. And this reacts also to treatment. So this is donanemab, an anti-amyloid antibody, lowering plasma phospho-tau 217 with about 10%. Next slide, please. The controversial aducanumab drug lowers plasma phospho-tau 181 with 13 to 16% in this study. Next slide, please. So if one would conclude on tau, we now have a test that works both for group level enrichments and screening, but also for individual diagnostics. It's getting there, and it really looks like this test. I think we will see tests that have become clinically validated and up and running, at least in Europe, in clinical chemistry routine during this year, actually. Next slide, please. With that, I would like to conclude and just mention then that the work on these markers have been, it has taken many years to validate them, and it has been very important to link the biomarker results to the brain pathologies they are meant to reflect. And this year we will see a lot of different studies examining these biomarkers in more diverse populations with comorbidities, and a lot of those things we need to figure out when starting to use these tests in clinical chemistry practice. Thank you.